And so I always tell patients, like, you can have your cake and eat it too, meaning we can treat your breast cancer effectively. And that may include for a period of time using adjuvant endocrine therapy if you're estrogen receptor positive. And, I am here to say, like, we can walk and chew gum at the same time. We can treat our breast cancer patients. We can offer them evidence-based options to help mitigate collateral damages of estrogen deprivation due to treatment. And one of those ways we can easily mitigate one problem is, when we can talk a little bit more about this separately, is, the use of local low dose vaginal estrogen and vaginal hormones to treat the genitourinary syndrome of menopause. Because for goodness sakes, why would we not try to fix the things that at least we can fix, right? Even if we're taking systemic estrogen off the table, either temporarily or permanently, that's not to say we can't talk about local vaginal estrogen. And we can also be very proactive about other ways, advice that we can help her navigate things from a non-hormonal standpoint. But women don't even get non-hormonal options. In the literature, when you look at surveys of patients, most patients report that less than half of patients, or a third of patients, 20% of patients, so a minority of patients, are offered any help, even non-hormonal. So often the conversation, it's not just about HRT, it's about just addressing everything. And just offering an antidepressant, that's not the only choice. There are other things out there. But women get none of it, right? None of it.
Yes. And I felt like I got more instruction at the very beginning when I hadn't even been diagnosed. They took me into a separate room and said, hey, you have a bad mammo. Here's what breast cancer treatment looks like. And I got this whole, 30 or 40-minute lecture. I was sobbing. And she said, why are you crying? I said, no, this is the first time I'm hearing I have breast cancer. And she said, oh, you don't have it. I'm just telling you, if you do, here's what's going to happen. And I thought, oh my gosh, we're going to make this big leap. And then like a week later, I did get diagnosed, but I didn't even get that kind of level of instruction about, hey, next up, hot flashes. But I feel like I just got thrown into the medical system.
Yeah.
Kind of the hook was set. So here's going to be your treatment, but there was not humane treatment.
Yeah. There's no discussions of the collateral damages,
right?
Whether it's to hormonal health, sexual health, cardiac health, bone health, mental health, none of that. All of the support, what I found personally, and it was 24 years ago. So obviously some things have changed for the better, but many things have not. I find most of the education that patients get is on the actual medications that they're taking, like what to expect after surgery, or, the chemotherapy, but it doesn't really extend beyond those survivorship issues or the other aspects of quality of life. Like that stuff is relegated to like a side note, if at all.
Yeah.
And something has to change, because the problem is that we have a growing army of survivors. Like most women survive their breast cancer, which is wonderful. We have early detection, we have better treatments, but women are living longer with breast cancer, even those who have advanced disease or metastatic disease, who may not be cured of their breast cancer, but they're living a long time. We have a huge army of women with DCIS that has an excellent prognosis, right? Earlier stage. And so they're living longer, 4 million plus in the US alone, right? And we're not even counting all of these women now who, through genetic testing, are finding that they are, they are at a higher risk. So they may be doing things like having a prophylactic oophorectomy. So they're being plunged into menopause early, but because they carry a BRCA mutation or another mutation, they also kind of have an X on their back. No one knows how to deal with them, and they're afraid to touch them as well. And so there's just growing army of women, and it's not going to get smaller. When we have better treatments, women are going to be living longer and longer and longer. And so who's taking care of them? Who is taking care of their estrogen deficiency symptoms? Because that's what it is. And you know what? We don't have perfect answers, but we do have some answers. And women really need to be able to have shared decision making, informed consent, true survivorship care, because we can't just treat cancer and just throw them to the wayside. You
We
know,
can't.
we
We
can't, but
can't.
that's what's happening. And
Yeah.
when I ask patients, how much information did you get? Like, I got a pamphlet about sexual health and it said, use lubricant and moisturizer. And I'm so that's not acceptable.
It's
That's
not
just
acceptable
fair.
when there's a solution.
We have very
Right.
clear solutions. And so I like to point to the sexual health part of it, because obviously menopause after breast cancer is a lot more than just sexual health. But
Mhm.
frankly, the sexual health collateral damage is actually something that we've got really good evidence-based care solutions for. And we actually have practice guidelines from the American Society of Clinical Oncology and from the
Yeah.
Menopause Society and from ACOG. So this is not even controversial stuff here. Like, we
Mhm.
actually have good solutions, but that is not getting out to women. And a good example was last year I spoke to the Young Survival Coalition annual summit. It's about 400 women in the audience, and I was just talking about kind of these general ideas. And I just was like, so can you raise a hand, or how many people in the audience has ever heard of vaginal estrogen for breast cancer survivors, why it's important, what it treats, and what the genitourinary syndrome is? And it was like crickets. Like, there was silence. Like, the room was silent. Like,
Uh,
very few people. And after we had kind of explained what the data is, what the GSM actually is, and how it
mhm.
impacts, and the solutions, like, afterwards, women were coming up to me. They were crying. They were like, "Why? You understand? I haven't been able to have intimate relations with my partner, with my husband, with my wife, with my girlfriend, with my boyfriend, whoever, in
Mhm.
years. It's broken up
Mm.
my relationship. I've gotten divorced because of it, or I'm afraid."
Tragic. Yeah.
Or for young women, I was single at diagnosis, and now I'm afraid to
Of
re-enter the
course.
dating world because I don't think I'd be able to have sex.
Right.
And so,
Right.
how is that acceptable? That is cruel and unusual punishment to
It
women.
is cruel and unusual punishment. And I've just got to say, if this was a male issue, I think we'd be talking about it.
Well, we are and we do. And I have a personal example of this. My father had early stage prostate cancer. He's great. He's doing fine. I went to his like second doctor visit with him. And the very first thing, that the doctor brought up was like, well, this is what it is. We're going to have these treatments, but we really are going to prioritize your sexual health after this. And so I'm thinking, great, I need to like sit here with my stepmother and my
Yeah.
father and
This is
what
a
is
fun conversation.
sexual health. But I was like, oh, yeah, that is important. And wow, I'm
Mhm.
so glad that they were being very proactive. And those men do suffer. I'm not making light of what men dealing with prostate cancer or other cancers are dealing with, but it is an integral part of the counseling. And I
Right.
was shocked. I was like, oh my God, in the breast cancer world, this certainly does not come up. And the
No.
reality is these women are on much longer, prolonged hormone deprivation and have a lot, actually, I think, worse symptoms than these men do. So, and the men are given lots of options and even shared decision making about testosterone. They've got Viagra, they've got all different other things. It's
Mhm.
priority.